Hi, everyone. Thank you for joining us. Sorry, we're starting a little late um, for today's lecture, but it is my absolute pleasure to introduce Dr. Cercek. She is a board-certified medical oncologist who specializes in the treatment of patients with gastrointestinal cancers, particularly colorectal and appendix cancer. Her research focus is in regional therapies as well as the development of new therapies for patients, including molecular-based therapies. She is the founder and co-director of the Center for Young Onset Colorectal Cancer, which has a dual focus of a dedicated research center, as well as coordinated clinical care for young adults with colorectal cancer. And I will let her take it away.
Hi, everybody. Thanks so much for coming. It's my pleasure to be here. So I'm going to talk about immunotherapy in colorectal cancer, and I probably won't take the full hour, but hopefully that'll leave us lots of time for questions in the end. So these are my disclosures, and I'll focus predominantly on early stage, but we can talk about later stage immunotherapy in our discussion as well. So I've broken down colorectal cancer, obviously, as everyone in this group is well aware, into rectal and colon cancer. And I'll talk about rectal cancer first, and specifically where we've made the most progress with immunotherapy, which is in a subset of patients with mismatch repair deficient, DMMR or MSI high rectal cancer. So that's about 5 to 10% of all early stage cancers. We don't actually know the exact number, but we're starting to get a better sense as we're testing more and more early stage tumors with next generation sequencing, and in this case, very importantly with IHC for mismatch repair deficiency. What we've known for a long time with all mismatch repair deficient colorectal tumors from data in metastatic disease is that they're less sensitive to chemotherapy. And this was actually first noticed in the adjuvant setting where patients didn't benefit at all from 5-FU that were mismatch repair deficient. And then we looked at this actually in our rectal cancer population. So we've been using total neoadjuvant therapy for rectal cancer at MSK for many years now. And when we first started treating, what we did was we started with chemotherapy up front, and we noticed actually in clinic that a proportion of patients didn't respond to induction FOLFOX chemotherapy. Most patients did, but a proportion didn't. And then when we looked back, we did a retrospective analysis, and we noted that those patients that were mismatch repair deficient, so we had 21 patients that were mismatch repair deficient that we identified, and then we compared them with a retrospective sort of a 3-to-1 pairing cohort of mismatch repair proficient tumors. And then we just looked at their outcomes with induction FOLFOX chemotherapy, and we noticed that of those 21, actually 29% of them either progressed or did not respond at all to neoadjuvant FOLFOX chemotherapy. And that was compared to 0% that were mismatch repair proficient, where everybody either responded really nicely or at least had stable disease after chemo. And so that was, of course, different once the tumors were radiated. Then they all responded, which we know to be the case with mismatch repair deficient tumors. They're very sensitive to radiation. But this progression of disease is really what got us. And at this point, in those patients, immunotherapy was already approved in the metastatic setting. So once they recurred or if they became unresectable at the time of progression, we were able to use immunotherapy, usually pembrolizumab PD-1 monoclonal antibody, and those patients all had responses. And so that kind of gave us this idea, plus how sensitive the tumors were in the metastatic setting, to use this treatment up front sort of as a first maneuver in this patient population on a clinical trial. And the trial really was designed in a very sequential fashion, where we just kind of thought, how much could we get away with just using PD-1 blockade? In our case, we used dostarlimab, which is a PD-1 monoclonal antibody, the same mechanism of action as pembrolizumab or nivolumab. And so we took the total neoadjuvant therapy paradigm, started with dostarlimab for 6 months, and then had a complete assessment. If the patient, which included an endoscopic exam as well as a radiographic exam, if the patient had no visible disease after completion of just 6 months of dostarlimab, if they had a clinical complete response, they were eligible for non-operative management, which has already been defined in rectal cancer, was already part of NCCN guidelines, and we at Memorial were very much familiar, and our surgeons, radiation oncologists with the non-operative management approach. If they still had disease, then we obviously didn't want to compromise cure, so patients underwent chemoradiation, and then again were evaluated and again had the opportunity of non-operative management if they had a clinical complete response. If they had residual disease, they were to undergo surgical resection. So this was kind of the sequential idea, where obviously cure was most important, getting someone to be disease-free was most important, but we just wanted to see what we could accomplish with each step along the way. So patients with early stage rectal cancer that were eligible for total neoadjuvant therapy were included. They had to have mismatch repair deficiency by immunohistochemistry only. We did confirm it with next generation sequencing, but all that mattered here was NGS. And initially we wanted a target of 30 patients, but this was subsequently expanded based on our early results. So we had two primary endpoints to start. One was overall response rate after completion of just dostarlimab or in combination with radiation, or a pathologic response in patients that went all the way, or a sustained clinical complete response for 12 months in patients that had a clinical complete response. And that we kind of equated a 12-month CCR to a path CR based on data in total neoadjuvant therapy, non-op management patients with rectal cancer, where the majority of patients will have local regrowth within the first 12 months. And then we followed the patients very closely on treatment and collected circulating tumor DNA. We had biopsies as well as imaging along the way, including PET scans, and then also during non-operative management follow-up. So these data were initially presented in June of 2022, where I was able to present the overall response rate. We had 14 patients at the time that all in a row, so 14 consecutive patients achieved a clinical complete response to dostarlimab alone. The trial was then expanded for more patients, and this then got PD-1 blockade into the NCCN guidelines for locally advanced mismatch repair deficient rectal cancer. So that happened in May of 23. So the most important thing is immunohistochemistry testing right away, because that really kind of determines then which neoadjuvant therapy paradigm the patients follow per NCCN guidelines. And then the second primary endpoint of a sustained clinical complete response after 12 months after PD-1 blockade was achieved. And I showed these data at ASCO in this past June, so now in 2024. And then, of course, our secondary objective was safety and tolerability. So these were the data as of June of 24. The trial is still ongoing, and we're actually presenting updated data at AACR at the end of April. But at this point, 48 patients were accrued. The median age was 51, so young, but a broad range, 26 to 78. Most patients had big bulky tumors, T3, T4 were the majority, and 85% of them were node positive. And then in terms of just sort of what their outcomes might have been based on the tumor location, the median distance from the anal verge was just 5 centimeters. And you can see some of the tumors really very, very low. So, many of these patients would have required an APR had they needed surgical resection. In terms of Lynch syndrome, so this is associated with Lynch syndrome. Rectal cancer in particular is about 51% of patients were positive. We tested 41 at this time, did have Lynch syndrome, a bit more than colon cancer, where we tend to see sporadic MSI tumors, especially in elderly patients. And then, as I mentioned, the most important thing is mismatch repair deficiency by immunohistochemistry. And then the patients were found to be MSI high by next generation sequencing with a high tumor burden of 53.6 was the median, but kind of a big range, but everybody was MSI high. And then we always talk about BRAF V600E, which we don't need to sort of belabor today, but the question has been in metastatic disease and colorectal cancer if patients that are BRAF mutated, because many of the patients with right-sided tumors that are MSI high also harbor a BRAF V600E mutation, and some have reported that they do worse in the metastatic setting. So we wanted to look at our patients. We only had one patient with a BRAF mutated tumor, but we believe that to be because they're predominantly right-sided, and these are obviously left-sided rectal tumors. So this is the swimmer plot, again, as of last year. We had 42 patients who completed dostarlimab, and all 42 had a clinical complete response, so still at 100% clinical complete response at the time. And then this is the median follow-up of the entire cohort for OS, which was quite long, but you can see it's staggered a little bit. Usually patients kind of come in bunches. Most of the patients did achieve a clinical complete response at our 6-month endpoint. We did have a little bit of a second endpoint because we wanted to allow time for the tumors to evolve if they were responding. And you can see just a little over a handful did achieve that clinical complete response at the 8-month evaluation. So I'll talk a little bit more about this in detail, but I think the most important thing is really to give these tumors time if they're responding, because most people do get there. Certainly in our case, everyone had. And then a few patients had a very, very quick response at 3 months. I don't have the data here to show you, but the responses are very rapid in terms of clinical improvement. Patients who are bleeding, have pain, note a significant improvement after just the second 1 or 2 doses. So just 3 to 6 weeks into it, rather, they have really significant clinical improvement. And then some patients at 3 months, the tumor's gone by all of our modalities, which again are endoscopic exam, digital rectal exam, as well as an MRI. But even if they achieve a CCR at 3 months, we still continue the treatment for 6 months, but we don't treat beyond 6 months on this trial. So all of these patients just got 6 months of therapy and then observation. And then this is the second primary endpoint, the patients that achieved a CCR12, so which was also met. So we had not seen any tumor regrowth at that time at a CCR12. So everybody achieved that. So they are durable, sustained responses. In terms of adverse events, very well tolerated, actually, which has been reported. So nothing unusual, nothing, new, maybe slightly better, but again, it's a small, relatively still small number of patients. We didn't have any grade 3 or 4 adverse events, and mostly kind of rashes and some fatigue were really the main complaints, and then also hypothyroidism, which we monitor very closely and can manage with levothyroxine. So an important thing that comes up clinically, sort of as this is now, real world practice, is what's the time to clinical complete response? Many people rely solely on MRIs. I really stress the importance of endoscopic exams, even more than MRIs. MRIs tend to lag a little bit, and also the tumors are a bit confusing sometimes when they respond. They're mucinous, which is very, very difficult to interpret on an MRI. So for us, as I mentioned, I'm really fortunate to lean very heavily on the expertise of our surgeons and also our radiologists who, are kind of comfortable saying this is probably mucin, let's watch. And so far that has worked really well. But in terms of sort of just composite, responses and time to responses, most people get there at about 6 months. As I mentioned, some people need up to 8 months. Interestingly, the biopsies normalize or become negative very quickly. You can see that the median time to a negative biopsy is 1.4 months. You all, I'm sure, have experience monitoring, rectal cancer responses, and they do respond endoluminally. So it makes sense that as the tumor is regressing, you simply can't reach it, with the biopsy. But we see that also in standard FOLFOX or chemo-RT as well with rectal cancer, that the biopsies do normalize. But I do think it's an important part of the evaluation for patients, especially if they're not responding. Biopsy is critical to see, is there anything there, or can we give this a little bit more time because it's just scar tissue. And then from a research perspective, and I think this will become increasingly more important and an important marker, but for us, it was really, really obvious that patients who had a complete response cleared their circulating tumor DNA incredibly quickly, Median time to response was 1.3 months, even faster than the biopsy, and they had a sustained response as well. The PET-CT is a little bit trickier. It was really, research purposes, and more than that, it was because it was a curative setting. We didn't know how patients would respond. We just didn't want to miss anything. So it's kind of an additional imaging modality. We don't usually image rectal cancer at MSK with PETs at all. So this was really for research. And it was a little bit mixed. Some did respond really quickly, some didn't. So it was not always, super helpful. But it was a nice additional piece to have. And what we did note is that for the patients that had mucin, the PETs were actually very helpful, because then there was no FDG avidity in that area that corresponded to a potential mass on MRI, and they felt much more sort of comfortable saying that this is probably just mucin, and we should watch these patients. So you can see in these graphs, patients that didn't fully clear their DWI signal, they did have resolution of SUV avidity on their PET scan. So perhaps helpful in that situation, but obviously not standard of care. So in terms of sort of, I guess, clinical pearls with this response, the large majority from what we've seen, of rectal cancers are incredibly sensitive to early immune checkpoint blockade. The responses are very rapid. They appear to be durable. We designed the protocol at 6 months. This was largely in the metastatic setting. We treat for 2 years, which for many of us seems like a very long time after the patient. Some of them achieve a response. 6 months seemed appropriate in the curative setting, or if we just weren't getting a response, we could move on to standard of care. But we definitely see that some patients do take a little bit longer. I've certainly seen that off study with some of the referral questions that come to us now that people are using this more in the community. So my sort of 2 cents is that if the tumor is responding, the patient is reliable, motivated, I definitely recommend continued close follow-up. But we don't know if it's just time. You treat for 6 months and then you keep watching, bring them back, or if it makes any sense to just continue PD-1 blockade. I think if they're tolerating it well, it's probably okay to give it, but we honestly don't know whether it's necessary, or if the immune system is already engaged and working. It just, in some people requires more time to get that TME completely engaged to get the responses that we're seeing. And then I would say, again, endoscopic exams and biopsies are important. Rarely these tumors can have a mismatch repair proficient component. Some Lynch patients can have sort of these hybrid tumors, in which case we would expect the mismatch repair deficient portion to disappear and to still have some potentially residual mismatch repair proficient disease. I think it's incredibly rare, but just something not to miss. And then I would say if there's truly persistent disease, then it's not necessarily necessary to jump to radiation. I'm very much a proponent of individualizing therapy in rectal cancer in general. We have the prospect data for omission of radiation, going straight to surgery, depending on the tumor location. So of course, that's something to think about. But if the tumor is lower, these tumors are very sensitive to chemoradiation. The issue, of course, with all of this, and the reason and goal of all of this was that we're seeing so many more young patients with rectal cancer that are interested in particularly in fertility, but obviously in long-term quality of life as well. So that's where kind of all of this is incredibly important, and where we've seen really nice outcomes with our patients. We've had 3 babies from patients on trial that had large, really sort of big, bulky, low tumors that certainly would have needed radiation and surgery, and are now, completely fine in terms of organ function. So it's definitely worth pursuing, in my opinion. So 100% clinical complete responses in the 42 patients. The responses are durable. The Azure study is a GSK-led confirmatory study with the exact same design, which was approved by the FDA. It was very exciting. It's a curative study, a curative intent trial that is not randomized because they accepted the high responses. And so this has now completed accrual actually this past summer. We're expecting the data are maturing. We're expecting it in about maybe a little over a year or so. They're looking for 2-year disease-free or organ preservation survival, but that is a worldwide study, so that will be very exciting and hopefully bring this therapy to patients across the world. And then, as I mentioned before at the beginning, all locally advanced rectal tumors should need MMR testing with immunohistochemistry, and if at all possible, confirmation with NGS testing as well. So moving on to the other part of the colon cancer, in terms of immunotherapy for mismatch repair deficient early stage colon cancer. So again, metastatic disease, we obviously lump it together. There's metastases, we treat it as colorectal, doesn't matter the site of origin, and we can use immunotherapy as first line in metastatic disease. We have approval now for single agent as well as combination, and those outcomes are really quite good. But thinking about moving this to the neoadjuvant space for colon cancer, I will show you some of those data. So in colon cancer, it's a little bit more common, about 10 to 15% of all early stage tumors. The standard treatment includes resection, obviously, as this group is very well aware, and then potentially chemotherapy depending on the pathology. We do have tumor agnostic approval for ICB and metastatic disease, which I already talked about. So it's another piece of the pie. So we had actually expanded our study to include all solid tumors outside of the rectum. So we've accrued several patients with colon cancer as well, and I'll be presenting those data at the end of April as well, but very similar approach. So it was for all mismatch repair deficient solid tumors. So it's induction dostarlimab for 6 months. And then if the tumor is still persistent, any kind of standard of care. So for colon, it was a surgical resection. Outside of the colon, it would be potentially radiation, chemotherapy, or surgery, depending on the tumor type. But very similar idea. And the niche study, I'll just spend a few minutes talking about it. It was really the niche 1, and the niche 2 is an expansion of it, was the first study to kind of ask the question of potential benefit of immunotherapy in colon cancer. And it was really more of a pilot study, a proof of principle study to say, how well does a tumor that will get resected very quickly respond to immunotherapy? What are the responses? What does that look like? More sort of from a scientific perspective, are there any actual responses, or do we just still do surgical resection, because that doesn't make any sense? And the study actually included MSI and MSS patients. So I'm going to talk about just MSI here, but MSS was also included. And actually, I do have some of the MSS data, which I'll show you in a little bit. So this is just the portion of the tumors that are mismatch repair deficient. Again, standard of care would have been just surgical resection. This study was done in the Netherlands, and so they did this very quick lead-in of immunotherapy preoperatively, where the patients were diagnosed. They had just 4 weeks of immunotherapy, so they had combination ipilimumab, which is a CTLA-4 blocker, and nivolumab, which is a PD-1 monoclonal antibody, 1 dose of ipi, 2 doses of nivo, and then surgery. And everybody had surgery at 6 months. The most important goal was really not to compromise curative resection. And then they collected tissue and plasma for ctDNA along the way. And what they saw was, similar to what we see in rectal cancer with 6 months of dostarlimab with our clinical complete responses. Here, patients received just 1 month of combination, and they had a 68% pathologic complete response rate. So everybody went to surgery, and 68% of them had no residual tumor after just 1 month of immunotherapy, and like a 2-week window, and then surgical resection. Some patients that had a complete response in the primary did have persistent lymph nodes. So not all patients were completely disease-free. So indicating here surgery still was very important for a proportion of patients. And of course, the challenge in colon a bit, and I'll show you those data, is who actually has a response or not. In rectal cancer, we can assess response, clinical complete response very well. Here, it's a bit more of a challenge. So these data were presented at ESMO and then published. Actually, these data were not, the study was published in NEJM, but then the data were updated at ESMO that showed 100% disease-free survival. The caveat here, though, is they all had curative surgical resection. So the question, in my opinion, is still, does everybody need induction immunotherapy, or would a proportion, and how large of a proportion of those patients been cured with surgery alone and wouldn't have needed any adjuvant therapy? I think that's a piece that is still actually really important to know in colon cancer, where resection is a lot less morbid than in rectal cancer. And many patients, it's easier than receiving treatment. There was a bit more toxicity. There was a little bit more toxicity here because of the combination. There's higher risk of grade 3-4 toxicities with the addition of ipilimumab. So even though there is incredible sensitivity, the question is, do we need it for everyone? Or a better question is, how do we identify the patients where we need it? And this was a Chinese study published in the Lancet Gastroenterology by Dr. Hu and colleagues in 2021, actually, where they gave 3 months of just PD-1 blockade, same patient population with colon cancer, and they added celecoxib to a proportion of them, but that didn't seem to make a difference. And here is about a 75% pathologic complete response after 3 months of PD-1 blockade alone. So super, super sensitive tumors, just 3 months, 75% of patients had no residual tumor. And then this was a study done by Dr. Ludford and Overman and colleagues at MD Anderson, where they administered pembrolizumab to patients, and a proportion of patients with colon cancer, they received up to about 6 months. Most of them, underwent surgical resection, and the path-CR rate was 65%. So again, just kind of roughly similar numbers, just showing high sensitivity of these tumors. What we don't know, and what's still a challenge here, is that the duration of immunotherapy was very variable. It was 1 to 6 months, as I just showed you. How much is necessary? Do we need just the 1 month? Does that then translate to enough of an immune response where all the micrometastatic disease is eradicated? Or do we really need longer duration? And then the question is, what are our goals if we're still incorporating surgical resection? I think that's a little bit more complicated. What we do know, and we looked at this, is that for the most part across all studies, and these are not limited just to colorectal cancer, the longer we treat with immunotherapy, the higher our responses are. And so this is something that I think we need to keep in mind as the field is considering potentially more non-operative management in these tumors. I personally feel, outside of colorectal cancer as well, with some of the resections like a Whipple or esophagectomy, gastrectomy, can be quite morbid if we can achieve these amazing complete responses, perhaps with longer duration of therapy. And so, as I've mentioned now a few times, in terms of assessment of a clinical complete response, we're spoiled in rectal cancer. There's been a huge movement towards non-operative management. So MRI and endoscopic evaluation correlate very well with the CCR assessment. In colon cancer, assessing CCR is very challenging. We've seen this now on our trial as well. We know from metastatic disease, when patients, have a tumor that doesn't look like it's responding and just sitting there, when we resect it, in data have been published, up to 60% of those tumors are actually a path-CR. There's just so much fibrosis that with any imaging modality that we currently have, we really can't call it. And that's a huge challenge. And this is, shown really nicely in the Dr. Hu study with PD-1 blockade from China that I showed you earlier, with the 75% pathologic complete response rate. This is their radiographic assessment at the end of treatment. So if you remember the initial waterfall, 75% had a path-CR, and you can see here the red marks are pathologic complete responses, and the radiographic responses were 30%, 40%, 50%. So looking back retrospectively, there's really such a huge discordance that it's a real challenge if we think about non-operative management for colon cancer specifically. So definitely need to improve our imaging techniques. So in terms of ongoing trials, many trials are still incorporating pathologic response. So they're doing kind of novel therapies, novel drugs, different combinations in MSI disease, trying to see, if we can improve pathologic response in colorectal cancer, which at some point I think it doesn't really matter if we're still thinking about surgical resection, if already we can achieve, very high, at least 3-year disease-free survival in those studies that have been published. So I think, as I've mentioned, I think for me, these studies really highlight the clinical impact of biomarker-directed therapy for early-stage disease. And our goal, one of my personal goals, is to take that out of to obviously continue to work on immunotherapy, but other biomarkers as well, particularly in rectal cancer. I think in colon cancer, we could pursue organ preservation. I don't think it's necessary, though, for everybody, because surgery can be quite straightforward and much easier than a long duration of treatment, let's say, for certain patients. The duration is unclear and inconsistent, and I think still remains a challenge. Longer duration would yield higher responses. And then I think we just need better imaging for sure. And then we also need a better assessment of complete response, and maybe ctDNA as our techniques improve, as our sensitivities improve. That may be one of them. Of course, the challenges here is, if it's still positive, it may not necessarily mean that the primary is positive. There may be some occult metastatic disease somewhere else that is shedding that we're just not detecting with our radiographic techniques. So it's not a perfect test, and then obviously, hopefully, better imaging will help us with that as well. And then I'll just spend a few minutes talking about immunotherapy beyond MSI colorectal cancer, and that is our mismatch repair proficient group. And I sort of gave it a smaller chunk of the pie here because, as I mentioned, I like other biomarker directed potential approaches, but obviously this pie really is like 95, maybe 80% or so of our patients with early stage disease that are mismatch repair proficient. So is there a role for immunotherapy in this patient population? It's certainly been looked at a lot in rectal cancer. There are now many completed studies and many ongoing studies just kind of adding immunotherapy to standard versions of total neoadjuvant regimens. In rectal cancer, it's a little bit of a challenge because even in the US, we're not that sort of standardized. Some people do long course radiation, some people do short course. Outside of the United States, not everybody does induction chemotherapy. Some people do much shorter duration of chemotherapy. So the issue here is it's very hard to compare the pathologic response rates, which seem pretty good with the addition of some of these agents, these mostly PD-1 monoclonal antibodies. But, the duration of treatment is very different, and we could achieve in some of the studies that we've published even higher here in the US, higher path response rate with standard of care without the addition of that. So I'll just say that that's a caveat as a lot of these studies come out, but certainly there is this interest for getting a response to immunotherapy, which I think is, important and exciting. And some of the earlier data, and this was the study that I mentioned earlier, where we focused on the MSI component. So these were the patients that were MSS. And again, it was a pilot study, proof of principle, few patients, half MSS, half MSI. And this study was later expanded, but the data that we have published and presented is for this 31 patients. But even in this population, so these were true MSS tumors, early stage colon, again, quick induction of immunotherapy, just a month, and then surgical resection. So they got them to surgery within 6 weeks of meeting them, but they gave them a month of immunotherapy of combination ipi-nivo, and more than 50% of the patients had a significant pathologic response, which was not expected because in metastatic disease, prior studies showed us 0% response. Now we've had a little bit more of these combination studies, some newer agents where we're starting to see some population that's responding. And that's really quite exciting because that suggests that, there are these kind of more immune hot MSS tumors, and there might be this population, especially with early stage disease, that does respond. And so we have a trial that just opened of neoadjuvant PD-1 blockade with balstilimab and CTLA blockade with botensilimab in mismatch repair proficient rectal cancer. And the idea of this trial is similar to our dostarlimab study, but these patients have mismatch repair proficient tumors, would be eligible for total neoadjuvant therapy. And we introduce immunotherapy for 6 months, but just 1 dose of the CTLA-4 and then up to 12 doses of the PD-1 agent, watching them very closely, assessing for, of course, response or progression. If they have progression, they jump onto standard of care. If there's response, then even if they achieve a clinical complete response, we still give them adjuvant chemotherapy because it is MSS disease, and obviously these are curative patients, so we didn't want to compromise that. And our primary endpoint is overall response rate after completion of just the immunotherapy or in combination with chemotherapy after, if they don't have a complete response. But it's very much kind of the similar sort of stepwise design where our goal is non-operative management. The ideal goal obviously is just immunotherapy with the chemo, omission of radiation and surgery, but we will see what proportion of patients achieve that. And then we have many scientific studies along the way to assess and compare responders and non-responders, as well as ctDNA. So I think in conclusion, I think the combination with immunotherapy in clinical trials is ongoing. It's exciting. It's happening in metastatic disease. I do think that we're definitely making progress. We now in metastatic disease have about 20% of patients or so with tumors outside of the liver that can respond to immunotherapy based on recent data with this combination, actually with bot-bal. And there's many other actual studies in combination in metastatic disease. And then now, as I mentioned, in both in colon as well as in rectal cancer, to see if we can find that population that responds. And of course, the ideal way is obviously to identify it and then preferentially treat those patients with immunotherapy. And this is a big team effort for all of us at MSK. And then, of course, our patients and their families and our sponsors. And thank you so much for your time.
Thank you so much, Dr. Cercek. That was a whirlwind of
Sorry.
good information. No, 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 it was so good. We have lots of questions in the chat. And so the first one is from Dr. Shrey Modi. He is wondering, is rash a biological marker for response in relation to the side effects? For example, in pancreatic cancer, having a rash with immuno or EGFR inhibitor is a good sign.
Yeah, that's a great question. So for us too, with anti-EGFR inhibitors, right, in colorectal cancer, the worse the rash, the better the response. That's not the case here. It's a little bit random, actually. We don't know who gets the rash, and it's usually pretty manageable just with steroid cream. What we do know with immunotherapy in general, and this is in metastatic disease and melanoma, everywhere, is that patients who have sort of severe high-grade responses like colitis or pneumonitis or hepatitis actually do tend to have better responses, and the idea I think kind of makes sense because it's just your immune system is completely revved up and gets confused and you have all these itises potentially with it, but then we do see kind of more robust responses, but it's absolutely not necessary. We've had for us it was few patients that had it and everybody had a complete response.
Our next question comes from Dr. Matam Muslim, and their question is, does PET have a role here for metabolic response? I think they're asking, this came after the colon cancer discussion specifically.
Yeah, so it's a good question. So we do in our study, we do use PETs for the solid tumors, including colon as well. I think it's helpful to a point. The problem ends up being that a lot of like these tumors in the lymph nodes have lymphocyte infiltrates, which light up on the PET. And then you're kind of stuck not knowing if the FDG avidity is actually the immune response that you want or residual tumor. We definitely see kind of the typical story that you would expect, SUV of 20 at the start, and then it decreases. And in some patients, it can get to normal physiologic, 0, but in some patients, it just sort of hangs out around 5, 4, and it just doesn't completely go away. So I think I would never rely on it solely but I do sometimes use it, if it's questionable. It's very, very tricky. And the lymph nodes end up being like kind of the bigger challenge because they're just so hard to image.
As a
But being
follow-up to
positive
that,
doesn't necessarily mean there's residual disease. So it's not, definitely shouldn't be used alone.
got it. So Dr. Cercek, what you were saying is that for solid tumors for both the rectal and for colon, that your team is basically using PET as part of the initial workup as well.
Yes. But we don't, it's not written as sort of it's part of the protocol, really for research purposes. My hope and my goal is that because we have so much data now that my radiology colleagues will take a deep dive and see kind of what we can learn. These are more just kind of anecdotal because they're not, for the outside of the rectum, some of them, if let's say gastric, then we did persist, we did proper radiographic, reads to make sure that the tumors responded. But for rectal cancer, we didn't, so it's tumor type dependent. We kept it very much as whatever the standard of care is. That's the imaging modality that we used. And in rectal, again, we just wrote it in because we just wanted to make sure that we didn't miss anything.
Dr. Rodrigo Pedraza has several questions, so I'll ask them one at a time just so that we make sure we answer all of them. The first one is, what about adjuvant immunotherapy for colon cancer? Should we wait for the atomic trial? What do we do in the meantime?
Yeah, that's a great question. So, I think that the atomic trial, hopefully we'll find out soon. The issue with it, of course, was that both arms, so I'll just say it for those of you who don't know. So patients with stage 3 MSI colon cancer were randomized to either FOLFOX alone or FOLFOX and atezolizumab for 6 months. And then I think that atezolizumab was continued. So the question is, is there a benefit with the addition of immunotherapy to a chemo backbone? I think a nice arm would have been just immunotherapy alone in these patients. And so I think, it's a real struggle for me, I can tell you honestly, giving all patients with MSI tumors just 3 months of capecitabine, which is what we kind of have to do at this point, or what's the right treatment. We are going to have some data reported also at AACR on adjuvant pembrolizumab for ctDNA positive patients, but all of those patients received chemotherapy first. So they received sort of their standard of care, and then if they still had positive ctDNA, then they were given pembrolizumab to clear it. My personal opinion, and I think what will probably work the most is if they get resection, then I would probably give immunotherapy as you're, I think, asking with your question, but we don't have the data right now to support that, to support omission of chemotherapy and to support giving just immunotherapy. I think with insurance, it's probably really hard to get, and then we sort of think about using ctDNA as a guide, which is also not very much sort of data driven, but maybe for like an 85-year-old with an MSI tumor where you really don't want to give chemotherapy, you just kind of feel better not giving it and watching. Because I think in the background of all of this, we need to remember these patients tend to do really well just with resection alone anyway. So, but it's complicated. I agree.
So another question from Dr. Pedraza. In your practice, does TMB matter for prediction of immunotherapy on MSS tumors?
No. So we looked at this in, the TMB10 or higher tumors in colorectal, and there's a response rate, but there doesn't translate to a benefit like a PFS or an OS benefit. So I tend to put my TMB sort of 10 and up, TMB intermediate patients or TMB high, but not MSI patients. I try very hard to put them on a clinical trial with the combination immunotherapy, whatever it might be, because I think they probably do respond better, but need a little bit more, not just single agent pembrolizumab, even though that's what's FDA approved. So I would still treat, I guess the short answer is an MSS tumor with a TMB of 14, I'd say, okay, this is pretty good, but let's do our standard treatment and then keep that in mind for later if we need it, even in metastatic disease.
And then the last question, I think we touched a little bit on this already with the question on PET, but specifically, is there a role of MRI to assess response for those folks?
In colon.
Colon.
In colon. Yeah, I don't think so. I don't believe that MRI is any better at reading either T stage or the end stage in colon tumors.
Thank you for the talk. Sorry I was late. I was in the operating room, but I had a question. What are your thoughts about microbiome and its effect on immunotherapy? I feel like I've read some literature where there's definite subpopulations that can cause decreased response. Is there
Yeah,
we
yes,
optimize?
and in melanoma, there's been definitely, data to that end and melanoma, and then there's been some data for probiotics. We do tell our patients to stop their probiotics, but I don't know of any kind of definitive, data. It is interesting though, if some of these differential responses are driven, by the tumor
Mhm.
microenvironment, which includes the bacteria for sure. We're definitely looking into that. It's very interesting.
Yeah. Are there any other studies that are out there which are trying to optimize the response of the tumor? I know that at Cornell, we were doing some short course radiotherapy followed by immunotherapy to kind of increase the immunogenicity of the tumor. Is that a
In
what?
MSS, you mean?
Yes.
Yeah. I mean, I think that yeah, there's several, different combinations with short course or long course. And that idea makes sense. And from the study at Cornell and then also at it was out of MGH in the metastatic setting, there was a little bit of data of these like 20% responses with combination of radiotherapy and immunotherapy. So those are the main ones that I know of, and then just kind of more novel drugs and different types of combinations, in that setting.
I would love to see like a prehabilitation that we do for our patients where we can kind of change their diet and change the microbiome into a something that
I
would
know, into
augment
something good, right?
therapy.
Yeah.
Yeah.
Yeah, I mean, there's a few studies. It does all make sense. We have a study of just exercise to lower like ctDNA because there's some really nice preliminary data that it does, So I do think there's more to that than we know for
Yeah,
sure.
totally.
Yeah. But some of these poor patients are so fit and they're so young and it's still like it just doesn't make any sense, either.
Totally.
We have one more clarification of the question from Dr. Pedraza. They were specifically asking, is there a role of PET MRI to assess response rather
Yeah,
than
so
PET
I
CT?
I don't know. That's a good one. Okay, I should have said that. I don't know, but Mark Golub, who is our phenomenal radiologist, is very excited by that idea. But we have not done it. But I think that might be cool. But that's the rectum. I just only know for the rectum. I don't know, even any early data about that in colon. But yeah, that or I was thinking even, since we're talking radiology that I don't know much about, but like a FAPI, which is a different it images like fibroblasts, like that might be better to assess, but I think that's more just like response, not necessarily for diagnostics, but sorry, I'm getting attacked by my dog. Just jumped in here, sorry. So anyway, I think that the PET MRI is a cool idea. We'll see.
All right. Well, I think your dog needs some attention, so I think we'll.
It's been an hour, It's
Yeah,
crisis.
I think it's our cue to close up.
definitely. All right. Well, thank you so much again for
Thank
the
you.
presentation. It's going to
Thank you for
be
having me. I appreciate it. Thank you so much.